Okay, Mel, I'm handing it over to you. Thank you everyone again for coming today.
Awesome. Hey, everybody. Thumbs up, sound check. And if you have your fireworks setting on your Zoom, you will also get fireworks when you do the double thumbs up. Hey, everybody. My name's Mel. Melinda Ramage is my formal name. I use she, her pronouns. And I'm a family nurse practitioner who is home based here in the wonderful Western North Carolina. Asheville is where I'm coming to you live from my office in an opioid treatment program that I work at. And then the other hat that I wear is like probably every single one of you on this call. I'm very passionate about perinatal substance use disorders, and I have the great privilege of working with a team of perinatal substance use clinicians across the state that make up our North Carolina Perinatal Substance Use Disorder Network. I'm super excited to be here with you all today, and in guessing there's probably a general consensus of who's here today, right? There's probably some people who are like, oh yeah, LAI bupe pregnancy. What's that update? And some of you may be like, I already know. And so what I would love to offer up is during this talk, please throw things in the chat while I'm on the topic. Don't be shy. I know Caitlin was very kind and said, hey, let's try to get through Mel's slides. I have 15 slides because I feel like this is a lot of opportunity for discussion. And I want to invite you to do so. I think we all benefit when we can hear each other's voices, and I want to make sure that we do that today. So hi, that's me. Let's get started on this presentation. I think it's a good reminder. It was a good reminder for me, but it's also a good reminder for you. This is being recorded, so keep that in mind. Here's a copy of actually the paper that we're talking about today. I had the privilege of learning a lot more about pharma. I partnered with some clinicians at Indivior to look at different ways that we were having emerging data around LAI buprenorphine. The monthly SUBLOCADE injection is the trade name you all know it as. And what this research, basically it's not a research study, right? It's a review of emerging data to understand what would she be doing when pregnant people or parenting people are on or interested on the monthly LAI buprenorphine. I would do want a full disclosure. Caitlin and I had a good laugh about this. When she sent out the invite, she made my last name way cooler than it is, y'all. She said Mel Ramage, which I actually wished was my last name. It's not. Ramage is still a good last name, but I have no financial disclosures regarding to this paper, and I'll explain more why I was interested from a perinatal substance use access, whereas my co-authors at the time of the publication and putting together the publication were employees of Indivior. So why are we talking about this today? Again, I'm not going to preach to the choir. You all know why perinatal substance use disorders is an important, and if I could talk about it every day, of why we need to get together on evidence-based practice and access, because we know that pregnant and parenting people are affected by this, their families are affected by this, and they die at rates that we could be doing something different about. So to me, when I think about all the objectives, right, your Bloom's taxonomy of why I'm sharing this manuscript today, for me, it's about, this is another opportunity for us as clinicians, of healthcare supporters, for families, friends, to make sure that pregnant people and parenting people, number one, have choices, have up-to-date data, and we find new ways and get rid of the old ways of which we continue to stigmatize pregnant people and parenting people in this population. So nothing like starting off with a soapbox, but I think I'm in good company with that. A reminder what LAI buprenorphine in the monthly injection depot, or bupe XR, you'll see those terms in the manuscript and in this PowerPoint. To be clear, I do mean SUBLOCADE in that 300 milligram or 100 milligram dose. That is an extended release buprenorphine injection that is, as mentioned, given monthly. It is FDA approved for opioid use disorder in adults. It is not pregnancy specific. FDA approval was in 2017, commercially available in 2018. And there's many reasons. I think that people perhaps were led to create that. I'm not a spokesperson for Indivior. I do not have that knowledge. I'm giving you some conjecture when I look at the literature and the addiction medicine colleagues that we all have of to why we make different or why we're motivated to have different access of medications. Patient improvement in what they want to experience from a medication. In my prior life, I was a diabetes educator. I think this is the same thing we talk about, whether we're talking about diabetes or opioid use disorder, right? Is the medication the right formulation and right dosage that makes things better for that person to achieve the goals that they want? And part of that, certainly with a depot, is we're always thinking about stability. Is that something that makes it more accessible? Is it something that makes me feel as a participant in the taking that drug or prescription, feel more stable? And obviously that was one of the goals when we looked at this. Again, that lower variability, that sustained serum level, once a month administration. We're going to talk a little bit about this. Thanks to when you have more than one product, right? That often can drive improvement of all products. Out in October 2024, a new package insert came out for SUBLOCADE that expanded the injection sites. Previously, that label was for just abdominal injection, but that 2024 expansion did include abdomen, thigh, upper arm, and buttocks. Interesting, right? What does that injection site flexibility mean for support and continued use in late pregnancy? And I did attach, if you look at that bottom corner of that slide, that is the research article that reviews that single dose study to evaluate bioavailability based off injection site location change. So let's go back to the manuscript that I'm referencing and that you all are here expecting me to talk about. Again, the question I think always in our pregnant and parenting population is there more data that can help improve our clinical decision-making and patient-centered decision-making? And the goal of this paper was to take what additional data we had and put it together for you all to be able to make a new level of decision-making. So that was across 3 columns. I love thinking in columns. The first was describing 4 clinical cases of pregnant patients who were on LAI bup or bup XR, SUBLOCADE, reviewing post-marketing surveillance data from Indivior, and that is international post-marketing surveillance data, as well as summarize relevant PubMed literature. And let's be really direct about what that is. Those are additional case studies that possibly some of you on this call were part of putting out into basically our national data source so that we can continue to make those informed decisions, right? Just like our patients, we want to make informed decisions based off the most recent information we can have. So let's take it one by one and let's talk about the post-marketing surveillance data. I'm going to give this shout out at the end. One of the things I want you to be thinking about is all of you who are prescribers, have you participated in post-marketing surveillance data? I think being able to look at this really challenged the way I look at that and how I may have participated in that, right? When we have post-trial opportunities to give the drug manufacturer information around desired effects, side effects, or possibly new effects, right? That's what we lean into with post-marketing surveillance data. At Indivior, they were able to capture 322 reported bup XR exposures in pregnancy. Again, as you know from post-marketing surveillance data, there's active and passive, and those rubrics are often lending for clinicians to give kind of more of a narrative off the cuff. So there's not a standard way that we're going to collect that data. Obviously, that you'll see that come up in limitations later. But what this did is give an opportunity for some information about what people were seeing in the field in real time over time. We were able to get 68 outcomes reported on SUBLOCADE exposure in the perinatal timeframe. The manuscript has a very large table, but what I wanted to show you here, I think, is one of the things that we were most concerned about when we look at SUBLOCADE in particular, or any of the LAIs that have the monthly depot excipient, which is what does that look like for our risk of loss right, in that first trimester, as well as congenital malformation risks. And when we look at those reported outcomes, again, that resulted in 49 live births. We had 11 reported spontaneous ABs at 14 weeks or earlier, and then 5 elective ABs. There was no patterns of fetal harm identified in that post-marketing surveillance data, of which we were able to have some captured outcomes. And then when we look at those other outcomes that are in that table, they align with our other buprenorphine literature, right? So when we're looking at this data, the team was reporting specifically looking, do we have any trends that make us concerned about risk of loss, risk of congenital malformation. And then certainly that second question of, hey, are we seeing any difference in maternal, fetal, or newborn outcomes when we look at exposure to buprenorphine in this formulation? And again, that full manuscript does have a much more robust table than I'm showing in this small time we have together. I'm happy to talk more about that. In addition to the table that we put together around outcomes, as I just summarized, we also wanted to add quotes. I think this is another beautiful part about post-marketing surveillance data. We're getting clinicians' experiences, right? We're getting patient experiences, but let's be honest, that's not the same as patient experiences reported by the patient, right? This is clinician interface, and so that looks different. Important, but those are different types of information we're getting, so I want to hold respect to our patients and what this means. But in general, we're looking at a lot of providers just sharing with the manufacturer, right, what that looked like, and that buprenorphine, for those who were on the LAI bup, that there were some overall positive experiences in their pregnancy and in their self-reported outcomes. So let's switch gears. Column number 2, if you will, was certainly a case report. We had 4 patients who were seen in a perinatal substance use disorder clinic and who had moderate to severe opioid use disorder, who all received buprenorphine XR or SUBLOCADE. 2 of them had already initiated the medication pre-pregnancy, and the other 2 had started that medication in second trimester. Again, obviously the manuscript goes into way more details of what we had, but in general, the outcomes of both sets of those cases, teams of cases, were full-term deliveries, expected birth weights, and all 4 neonates, none of them needed treatment for NAOWS or what we used to call NAS, and there were no congenital anomalies. Below is a small table excerpt summarizing that, but again, if you also have the manuscript open, you'll see a much larger team. So again, giving you that summary of what we're looking at. Is there any data that's emerging that makes us more concerned versus does everything so far look like what it does in the general buprenorphine in pregnancy and parenting literature? Last column was looking at our other case series. Again, there are more case series on bup XR that include the other LAI bup, which is by Brayburn and is called Brixadi, but this is only SUBLOCADE. We really wanted to keep it just to apples, y'all. So this is, again, looking at 4 clinical studies that were published between 2023 and October of 2024, looking at what findings that those had. And again, we saw some similar trends. Again, consistency with the previous clinical and surveillance data that I just talked about, and overall buprenorphine maternal data, right? That really we did not see any trends that suggested there was any new maternal fetal or newborn changes in outcome risks, and that overall that supportive safety, which is really our big question of, is there an increased risk of loss? Is there an increased risk of congenital malformation? And certainly, what are we looking at when we think of third trimester risks, delivery risks, and postpartum risks? And in that literature review, we did not see anything different, and the findings were consistent with those 2 other columns that I just talked about. So it goes without saying in this group, I know you are very well aware that there are many limitations to a review, right? And so I invite you all to lean into the two I underlined when I think about limitations. I am always happy that we are making clinical decisions with more and more data. That is the goal of this manuscript, is that we need more data to be able to make our clinical decisions. And when that data is available, well, by golly, I want us all to have it. I always want to hold space. I'm going to switch hats for just a second. When I think about my treatment hat, I need to understand more of that patient experience, right? And that's one of the things I think that we can really think about in the future. And something certainly we may be interested in talking about when I'm done talking is really talking about barriers and access to different formulations for patients, right? Because when I think about treatment access in the perinatal setting in particular, postpartum setting as well, but particularly in the perinatal setting, I know you all know we have the hot potato game, right? Because if you live in the maternal child world and someone has a perinatal substance use disorder, that's a hot potato, and the maternal child clinician wants to get you out of that clinic, right? Versus if you're in the substance use world, if that person is pregnant, then there's a lot of fear and stigma that goes with that. So I think this is an opportunity not only to call out that do we have a lot of gaps in the literature around not only LAI bup, but many things around perinatal care in general. Where can we lean into the parts that are often most important to our patient, in addition to our call to do no harm and make sure that there's up-to-date safety data. So I do want to give a shout out to the specificity of maybe why this article exists, and maybe why some of you are here today, is because there's a lot of concern in the literature. Like if you all Google NMP, there's actually concern of teratogenicity in the literature that is outside just this excipient, right? We don't just use this for an excipient for this particular preparation of LAI buprenorphine. All the monthly buprenorphine products have this as their excipient. There's a lot of veterinary literature about NMP. And so just a warning, if you Google that, you will learn a lot that this has been something we've been looking at for a while. In the original, when we look at their original product handout and the updated version, just a reminder, right, that the NMP is the excipient that we use in long-acting monthly injectable buprenorphine, both formulations by both companies. I'm focusing on SUBLOCADE today. In SUBLOCADE's data, we had preclinical animal studies that raised concerns that at high doses and repeated administration, that there was concern for teratogenicity. There have been subsequent reproductive and developmental studies in rats and rabbits, and that you can find that in the up-to-date prescribers information on SUBLOCADE that is now in every SUBLOCADE container when you open it, or you can find it on the web, and I'm happy to put that in the chat. But what we have found in those additional studies is that there was no fetal, external, visceral, or skeletal abnormalities, and no maternal toxicity at the human equivalent doses, right? So we took that original data, and the company did repeated studies. So the other thing that's important to note is that the exposure of the buprenorphine XR that we administer clinically is limited to once monthly, with a peak that diminishes within 2 days, which is not what those studies, right? Those studies are done at much higher doses than we use equivalently in humans. And again, I'm happy to pop that up on my screen when we're all done so we can look at the product insert together, if that would be helpful. So again, going back to that US product label that was updated, that the NMP effects language was removed based off this newer safety data. And BUP-XR is not only not contraindicated in pregnancy, nor has it been in any of the approved markets globally. So I think those are important things to talk about. So again, I want to give a slide dedicated to really probably the topic for why most of you all are here today, is to talk about NMP and what those new studies showed for us in support. I'm going to bring a little levity before we go back into that. This is a infographic that we used on a poster. We presented this information at CSAM, so the Canadian Society of Addiction Medicine. You can open up the full poster if you scan that QR code. And this gives some summaries that I'm about to talk about. I do want to tell you I'm very sad that I did not get to go to CSAM for many reasons. I wanted to meet my Canadian counterparts to see how they do some things in addiction medicine differently. Unfortunately, if you all are those of you who are from smaller towns, you know that sometimes the small town connection to the bigger town flight gets delayed and then you've lost your flight. I want to tell you that y'all, I didn't get to go see how we do addiction medicine in Canada because this conference was at the same time that Taylor Swift was ending her Eras tour. And so once I missed my flight, I could not get to Toronto for 2 days. That's how many flights were booked up to see Taylor Swift. You can imagine my surprise at the ticketing desk when I was trying to rearrange my flight. And I was like, certainly we can get me to Toronto tomorrow. And they were like, we absolutely cannot. And we did not know why. And I was pretty certain that there was not that many people from the United States traveling to CSAM. And turns out I was correct. It's because they were all going to Taylor Swift instead. When we think about the clinical implications that I hope this manuscript and our further conversation promote is we know that medications for opioid use disorder is first line in pregnancy and postpartum, and that with the current data we have that LAI buprenorphine may be an option for pregnant people, that we don't have any data that contraindicates what we know from baseline buprenorphine data in breastfeeding and postpartum. Therefore, how do we continue breastfeeding and postpartum continuation along with MOUD, which may be using an LAI buprenorphine. And most importantly, I think all of you who do medications for opioid use disorder treatment in pregnancy and postpartum are already having these conversations, right? You are already talking about the risks, the known risks, the unknown risks, and then what is the patient-specific target, goal, and shared decision-making that is important to them, right? I know our clinical guidelines back from 2019 recommend not changing medications during pregnancy, right? That we don't want to disrupt what treatment goals have already been achieved. So again, that's one place I think that LAI bup may come into play. Additionally, what does that look like based off of what access people have, right? So again, I think I am probably beating the dead horse with this community of, I think the goal really of this additional data is how do we support decision-making with our patients with more information? So this is a summary of what, again, we found in the case reports, the literature review, and the post-marketing surveillance data. Nice little plug. Maybe you're not thinking about reporting to your post-marketing surveillance data when you have a medication that you're prescribing. I certainly want to challenge you to think about that. And with that, I'm going to stop talking. I'm going to stop sharing my screen, though I'm happy to share again. And I would love to invite us all to have some conversation.
Thank you so much, Mel. It was great to be able to synthesize the paper down to those slides. I did put the link to the paper that is available open access with not behind any firewalls online. I'll drop it in again for those of you who came in a little bit late so you can access that paper and the references on your own. But I'd like to open it up with any questions that people have. So please feel free to put them in the chat, and then we'll also open up for people to ask questions verbally. We do have one question so far, Mel, that is about injection sites. So you kind of mentioned that and how that was updated in the recent prescribing information. And can you talk a little bit about if any of that came up in your review of the literature about injection sites and any challengers or facilitators, especially in the context of the updated prescribing guidelines?
Yeah, absolutely. That's a great question. Full disclosure, my first answer is actually, I don't know, right? In the current landscape because those expansion of the like an expansion pack, like it's a video game, right? The expansion of the injection sites is fairly new. So I want to hold space that post-marketing surveillance data was actually when the injection sites was limited to the abdomen. Again, for those of you who've worked in high-risk pregnancies, I feel like there's a culture of comfort with abdominal injections in pregnancy, right? For those who have been doing heparin and then Lovenox injections, right? There may be increased comfort in injecting the abdomen in a 37-weeker, and some may say absolutely not. There's also some patient comfort that feels uncomfortable to them, right? Again, I am not an obstetrician, y'all. I don't even play one on TV anymore. But when I explain to someone that there's multiple layers of tissue before they would be able to get a sub-Q based needle towards their fetus, the truth is, if that feels uncomfortable to them, it feels uncomfortable to them, right? And there's probably, and for all the right reasons, right? And so respecting that. So I am curious how being able to, again, expand the injection sites will perhaps increase comfort with this medication throughout pregnancy compared to when it was only abdominal. And I welcome if anyone's had experience with that, especially in the last few months, the last 7 months actually, where we've had that change. If you all have seen any patient shift, like were some people excited that they could inject in the arm and the leg? Were some people like, I'm fine? I'm curious what y'all's experience has been.
Yeah, I would like to echo Mel. We would love to have some interaction, especially because I think a lot of people in this call are also practicing clinically. And even if you just have a one patient you've had, like that is still a very important patient interaction that you can share. So thank you for interactions on the chat. Someone just chatted, for example, that they've moved more laterally in the abdomen. I'm assuming that's what the chat is saying as the pregnancy progresses and not had any problems. And some people have gotten in their arms. So any other experiences people have, please feel free to share. The next set of questions is about dosing, Mel. And so
Mm.
if you could talk, I know that was covered a little bit in the paper. If you could talk a little bit about dosing, and from two different perspectives in particular that have been brought up. One is the two dosing options that we have with SUBLOCADE, which is the 100 or 300. And then also, was there anything that came up in your literature review about the have patients having withdrawal symptoms or any other symptoms that are indicative of under treatment as they got after getting in the injection and needing additional sublingual buprenorphine, for example, anything related to dosing?
Absolutely. Yeah. Another great question that, again, I'm not going to pretend that the additional data I presented in this manuscript says something that it doesn't. We do not know, right? So anecdotally, what we've seen, certainly if you look at the 4 cases, all of the cases were on 300 milligrams the entire pregnancy that did not switch, right? When we look at the new prescriber information that came out and was updated in October, not only did that update the language about pregnancy and the NMP, it updated sites, but then it also gave that descript language that now with SUBLOCADE in particular, you can give that first injection of 300 milligrams and then a subsequent injection 7 days or later, earlier than that 4-week window. And then there's, as always, that space that says, right, not only in that prescriber insert, but also I think when you look at the literature that describes any of the LAI bupes is following that algorithm that is set, that's 300, 300, and then 100, but always listening to the patient's experience. And yes, absolutely. When we saw post-marketing surveillance, oh, go ahead, I'm sorry. Okay. When we looked at post-marketing, the surveillance data, that information was a little bit inconsistently reported that we really couldn't, like, if you look at that table, if you open up that table right now, you will see it is all over the place enough that I certainly would not give any recommendations out of it, right? And I think that's and that's and I see Tricia saying agree, right? It's a little bit everywhere. We don't know if there is a specific, I think, dose regimen to do. I think if you're gonna, I think I will say clinically, and I suspect you all are already doing this. You know, a reminder that it takes 4 months plus to stabilize on the LI buprenorphine products, right? So not only do we have the 300 back to back, you may go to 100 and then go back to 300. But certainly in this population and the regular adult population, I would not be shy of supplementing with transmucal buprenorphine along the way to be able to maximize benefit for the patient's experience of withdrawal and craving. If anyone else wants to comment on that, I invite you to. Because again, I think that is maybe, you know, now that we're gathering some data that, right, and let's be honest, I think many of you have gathered this data already in your clinics. You all have had people who've already come to you in the second or third trimester and have been on LAI bup, right? And now you're like, all right, we're going to watch what's happening and make that decision about what's going to happen next, right? And again, I want to remind everybody that when I'm saying that, I am talking about SUBLOCADE, and I'm not talking about our LAI bup in the weekly injection that I know is under clinical trial as we speak. Other thoughts about that?
Thank you, Mel. Kind of on that note, there's been a couple questions about like logistically, if someone is on SUBLOCADE and then needing sublingual films. I put my clinical experience in the chat. My nurses are here, so they'll tell me if I'm wrong and what I said. But did you come across anything related to access issues in particular that came across in your literature review or areas for future research that you've identified?
You know, that was an interesting thing to me personally, clinically speaking, is there was not like the post-marketing surveillance data, we did not see a lot of that. That was not one of the trends in the data. But me clinically, I've definitely experienced, right, that there are some access barriers for LAI buprenorphine based off your clinical setting that I think is important that we address as a community.
And then another question is about the neonatal outcomes that you went over. And so we all, those of us who read this literature, sometimes get frustrated because every study sometimes uses different definitions of how they define outcomes related to NAS and NOWS, for example. So that's just one example I'm giving off the cuff. But anything in regards to consistency of the research that was done, or is it pretty heterogeneous with regards to your review of outcomes from the fetal and the neonatal side of things?
It was very similar, which again, which was one of the things that when we reported out that we were finding that those the postmark, like when we look at all three of those columns, that the findings were consistent to what we see in the larger buprenorphine and pregnancy literature. Yeah, so no new trends when we looked at that data.
Okay, Mel, I would say now we can open it up to see what questions. Thank you, everyone, for being so engaging in the chat. I'm trying to do 5 things at once. I'm not very good at this, obviously.
No, you're doing
I'm
great.
trying really hard. So I would like to open it up if anyone has any questions or areas for discussion for Mel and for the group. If you want to raise your hand, and then we'll call on you.
In general, I'd be curious with raise of hands or thumbs up emoji, how many of you already have been experiencing pregnant people showing up in your clinic on LAI bup, the monthly injection? See a few. I see a few. Has there been anything that have come up for you all that particularly I think with the patient's experience that is important. Do you think that we need to look at next as a community when we look at this again? Knowing that, sure, if we could do a giant randomized control trial about this medication and all the ins and outs of correct dosages, that would be fantastic. What else would it entail?
Bill, you have a bunch of hands up. I think Jan was first.
Yes,
Go for it, Jan.
Jan, go for it. You're muted, Jan.
Okay, there we go. Hi, got it? There we go. I just a little background, the part that bothers me a little bit about this. So going back to Reckitt Benckiser. So Suboxone, when it came out, was a tablet. They were losing their patent, and then the film came out. Then a drug called Boonaville came out, which was put buccally, and 2 months later, Suboxone was able to be used buccally. Then Brixadi came out, and all of a sudden, we have 3 different areas that we can now give the shot, which is crazy because SUBLOCADE in the arm, really? I'm just a little suspicious of Indivior with this recommendation. I know these numbers in the study are not that large, so I'm still a little nervous using the injectable for pregnancy, and I just wanted to get what you guys thought.
Yeah, Jen, so can I do that thing to make sure that I'm hearing you correctly? I hear kind of 2 tracks. Like one is the location of the injection, and I hear you asking, hey, if we were doing it this way, right? Why did all of a sudden we look for more sites, and can I trust that those sites are going to be adequate sites for the treatment of my patients with this medication? Is that like
No,
one part,
actually,
right? Like when you think about the arm.
Yeah, well, I mean, again, that's, I guess, just 3 things that Indivior, and then giving the shot without the 16 milligrams for a week before, almost seems like a copycat to compete with another product, Brixadi. Now, the weekly Brixadi doesn't have the preservative, which appears to be a safer way to use it. So I guess with the preservative, I just feel a little nervous that Indivior seems to have a history of me too, is I guess the way I'll put it. So I'm not really asking because I think that giving the shot in other areas, and that I've been using the shot since 2018, is absolutely ridiculous. I mean, with the size of 300 milligrams in sub-Q in the arm, yeah, I don't think so. I mean, they're complaining about it in the abdomen. So I guess the crux of my question is, I'm a little concerned with the company sponsoring, saying, hey, no, there's no effect on the babies by using the injectable with our preservative. And I guess that's where I feel a little uneasy doing that.
Yeah, no, and I appreciate you sharing that comment. I'd love to get always a disclosure. Again, I don't work for Indivior. I was not paid by Indivior to do this, so I'm going to give you my opinion, and then certainly
They sponsored this paper, though, right?
They paid for the staff members who I worked with on the paper. That is correct.
Okay.
That is correct. The clinical team I worked with were Indivior people. That's right.
Okay.
I was the outsider brought in, right? And so, Jan, I think when I think about why this is important, right? Like holding space, I do not identify as a researcher, right? I'm a clinician who gets to play with a lot of you on this call and doing research and get to grow and get smarter that way. And I'll tell you why I think this paper is important is because Jan, whether it's in my OBGYN setting or my opioid treatment program setting, I am meeting people who are already on this medication and they're pregnant, right? The cat is already out of the bag. They are farther down the road. And for me, it is super important for us to continue to have that quest of knowing what safety data we can, right? Like, yes, do I want the perfect data? Absolutely, I do. But I don't want the pursuit of perfection to get in the way of increasingly informed decision making, right? And I get on my soapbox, as you can tell, because my voice rises and I sit up a little higher. But this population has been so stigmatized and so alienated in so many other ways. I want to make sure that when we're coming to the table and potentially can increase the stigma and shame someone feels based off what medications they have or have not been on, I want to make sure we have up-to-date data and I'm giving people accurate information and taking away any other way that person could experience shame. I'm never responsible for someone's internal processes, but I'm sure and responsible for what data that we can continue to gather and question and make sure that when I'm meeting people where they are at that place, that I can give them the best data that we have and support them where they are with, again, the most accurate information. So holding space that I think those are what you described and what I described are kind of two things that can be true at the same time, right? We're skeptical about data. We're skeptical about how people access all of our data, right? We want to be committed to good data, and I never want to get in the way of emerging data that really can make an impact in clinical care and patient experience. I welcome other thoughts.
I was just going to, Barbara Prilla, I'm a MFM physician at University of Kentucky in addiction medicine, and just take care of pregnant women, but have the luxury in our state of taking care of them for a full year postpartum. And I couldn't agree with you more. If someone's already doing well, whether it's SUBLOCADE, Vivitrol, et cetera, I try to keep them on it. And for all our postpartum patients, especially those that we think are going to do well with injectables, we are really, proponents and prescribing a lot postpartum. But I do have to say, and I know there's not as much data out there, we're prescribing Brixadi in pregnancy just because there's lower solvent, the same solvent, but it's a lower dose. And we have the option of not only different sites, but different strengths, if the 64 is not enough, et cetera. So, I know there's more data out there with SUBLOCADE, but it just intuitively makes more sense to me. And it's, we hope we can describe our experience in the literature, but so far, we haven't had any major problems.
Is the Brixadi lasting though? Because this is my problem. I've used Brixadi since it was released. When 20 to 25 of your patients come in initially and get the shot at 128 and tell you that in 3 weeks they're in withdrawal, they're not lying to you.
No, not. Yeah, but I find the same thing with 100 of SUBLOCADE. So, some of them you're going to have to, give them some sublingual and then make a decision about, going forward, their monthly injections, how often they are, and what concentration. Yeah.
And what I hear both of you highlighting is I'm going to shout out to Courtney Wilson, who's one of the pharmacists I originally worked with when we were creating our perinatal substance use program, right in the hot potato that is perinatal medications. And she always says, you dance with the one that brought you, right? And I think, Barbara, I think that's what you were describing. And again, continuing to listen. What I hear you all describe is continuing to listen to patients, continuing to present shared decision-making. I definitely don't think we have any medications with opioid use disorder that we're like, oh, this is the one everyone should be on. But we are definitely improving our options for patient voice and choice, right? Again, I like to make the diabetes reference. Man, if you have diabetes, I have so many medication classes and then so many meds in the class to offer you, right? So I think we're moving in the right direction when we have data that supports more options for patients, that patients can tailor their treatment goals and treatment needs. Josh, you have had your hand up very patiently, and thank you for that. I think you're next.
No worries at all. Thank you so much. I guess my question is a little bit more just around having, another way they mentioned starting SUBLOCADE is giving a 4 milligram test dose and then jumping straight to the 300 milligrams. And I've been a little bit more fearful of doing that in my pregnant patients because I feel like I just feel like I've seen precipitate withdrawal in pregnant people before, and it's not very much fun to be part of. And I was curious, sort of, if other people have experiences out there around this, or not. Thank you.
Yeah, good to see you, Josh. Anyone want to comment on that?
Trisha, I think you have a comment on that.
Yeah, I have a couple of comments. One is that, interestingly, going to ASAM and talking to the Canadian folks, and not in pregnancy, but they were doing direct to inject with the SUBLOCADE instead of Brixadi, and having, as long as the patient didn't have a history of precipitate withdrawal, which is a great caveat, just because the peak is somewhat delayed, just the same with the weekly Brixadi. So just an interesting thing, because I agree 4 milligrams is absolutely the wrong dose to give anybody if you don't want to precipitate them. So you either want to start really small or go big. And then the second one is, my second comment is just to echo the MFM and say that, we're always balancing risks and benefits in pregnancy. And I was one of the reviewers on this paper and was really kind of angry at Indivior at first because they did put out the first, for the longest time, we didn't use it because of their package insert. And so, yes, I want to say we need to be cautious, but at the same time, we need to treat patients equally and really expand, getting on Mel's soapbox with her to expand access to different medications.
Trisha, my soapbox is big. There's room for everyone on this call. Come on, because this is not a zero-sum game, right? This is not like it's MOUD treatment or like no exposure, right? We're asking bigger questions here, and Josh, I appreciate that question. And about, again, I don't want to pretend that this paper tells you what the right course of dosage is in any of the formulations by any means. And we are continuing to figure that out.
Sangeeta, I'm sorry, you had your hand up earlier, and yeah.
I feel like a lot of this has been said, but it's for Josh's, a lot of the reasons why our clinic can't do it is because we don't buy in advance and bill later. We just don't have the money to do that. And so there's no, even if that sounds good to be able to let someone get Suboxone and watch them for a little while, we just can't. So it almost immediately people have to take it home and come back when I can get it delivered. But I think one of the big things, and I've seen this for both my patients, and I brought this up, I think that with the long-acting injectables, we want to set it and forget it. And a lot of like carceral settings and even clinicians have sort of given the injection and don't think about, and it's not reaching steady state until 4 months. And so I'm not still unclear what that means. Being on 8 milligrams of buprenorphine doesn't automatically it's not equivalent to like 64 milligrams of Brixadi immediately. So people are going to experience withdrawal. And so a lot of my patients do not get sublingual for their cravings or just like a check-in, and it's seen as, they're just asking for more or they're trying to sell it. And that's all patients, birthing persons or not. And I've experienced that right now. And I had like a couple of patients come into the hospital. And it's tough. You're in the ER or you're in labor and delivery, and these are people that don't know it, and even psychiatry doesn't give them any extra because they're like, oh, they got 300 milligrams of SUBLOCADE, they don't need any more. And I feel like I wish, that's why I put it in here. I was like, it's such a loss that we all know that we should give extra, but no one's actually ever writes it into their paper of how much they gave or says this should be given. I feel like it's maybe a line in some papers that they gave sublingual extra, and no one talks about it any more than that. But if you talk to any person who gives long-acting injectables, we all talk about how we give a little extra.
Right. And that's continued. Yeah, absolutely. Two arms popped up when you were saying that, Sangeeta, so I'm guessing that they are going to be about this. Arthur, I think you popped up first, and David right after.
Yeah, no, I mean, that's just true in pregnancy in general. How many times have you been working with an outside methadone clinic? Nope, they're on a stable dose in their third trimester. They don't need more. It's like they need more. Like we struggle with this throughout pregnancy because people don't understand physiology of pregnancy. They don't understand a lot of things. So I think we're constantly advocating for the patients we take care of. So I think it's another manifestation inside and outside of pregnancy. It's just people who don't want to deal with addiction just sort of don't deal with it. And it's really frustrating, especially in the carceral settings. That's been our big fight lately. Like, can you split dose? No, we don't split dose. Why are they miserable? Like, well, I'm gonna have to increase their dose, which is kind of silly. But if you're not going to split dose, so I think it's part. It would be great if someone put in the paper everything 100%. I think this part, it's a population that we know we take care of them that are, it's a marginalized population that's further marginalized, and it's just really difficult. So we just have to use education as best we can and all the advocacy we can find.
And I think I heard Sangeeta call out that the next person who's going to publish a case review needs to put that part in it. That's what I also just heard. Right? David, thank you for being patient.
Oh, no problem. Thanks. It's great. I think one of the issues also is what's best practice and what's the best we can do with that patient. So one of the things I like about the pills and the daily and getting people in, it's kind of, there's so much more to their treatment than just, like you said, set it and forget it and giving them the shot. For my pregnant patients, when we can, and it's not everybody, but the ones we can engage in coming in weekly, it's incredibly useful. And I think the long-term outcomes I'm seeing with those patients is much better. And so I think we have to balance the ease of the monthly injection versus weekly versus, the daily tablets. That's why I like the idea of a weekly Brixadi, because I still want to engage with those patients. There's that reward, and again, not trying to punish the patients, but if we can get them to connect, that's where I think a lot of their treatment successes that we've seen is getting them into weekly groups. I've got patients now that I've seen for 6 years for almost every, I've seen them 200 times. And they've done much better. Now, those may be pre-selected, the ones that are willing to do that, obviously. But so I think we need to have multiple tools, but I do still think there's a role for the daily and weekly because some patients need that external control that'll help them to keep coming back. So that's just a comment on that.
Yeah, thank you. I hear that as a yes and, right? Like
Right.
a yes
I
and.
love the idea of the injection. I'm all for it, but I also we can't discount all the, therapeutic values of groups and everything else that we're doing as well.
And how medications can be contingency management versus, like you said, sometimes medication access in healthcare can be used as a punishment, right? And I hear you calling that thin line of you got to always be assessing to make sure which one and with what patient consent, right, is happening.
And I think what you just said is it's not a punishment, it's the reward. The medication, that's how we've used it, by the weekly. And so I don't think you withhold, it's you kind of reward. And so I think it's a different mindset.
Yeah, and David, this might be a hard soapbox for us to get together on at the end, but I also want to hold space. Like, full disclosure, I'm sitting in an opioid treatment program. And when I think about perinatal substance use in particular and the demands on societal, cultural, family expectations of pregnant and parenting people, I always want to hold space as a healthcare clinician that I can get pretty me focused, that their time is best spent with me, and where do we support what they need, but then also invite them to be able to get those needs met in other social context, right? Again, I'm sitting in an OTP. This is the motherland of me-centric substance use treatment, right? Like I want to be full disclosure about that. And so, I think that's a yes, and that there are some, I'm sure, patients in your clinic and others that are like, no, right? Like, no, I want to keep coming weekly. This is a helpful structure. And then there's going to be a time for some that are like, I think I really want to do other things that support my recovery and health goals that don't belong in a healthcare clinic, right? So yes, and.
Yeah, I agree. Absolutely. We got away, the original model that we were started was you've got to go to NA every week and so many meetings, and that we got rid of that very quickly because there's a whole argument of why we got rid of it. But what we found is that the groups, it's not me, it's the groups, but I do think we need different tiers of care where I almost feel like jumping on a van and we need to be given injections to a certain population and their OB care, their prenatal care on the street and their ultrasounds on the street. And we're working on developing that. And that's one group because that's where they are. And then we've got other people that have really benefited from our weekly clinics. And, and I'd rather somebody go to a job than they go to an NA meeting. That's kind of what you're talking about. So I do think it's not one model. It depends where our
Right.
patients are and where they need. And yeah, the patient that I'm giving a Brixadi injection once a week at the homeless shelter may not do as well as the one that's got a job that's coming every week getting therapy. But for them, that's best they can do and better than the options. And so we're constantly making choices. Like I said, is it
Yeah.
Brixadi, is it Sublocade? We don't know using everything out there is much worse option. So we're risk. It's not harm reduction versus ideal treatment. Like you said, it's all those things.
Yeah, and since we're getting time to close, David, thank you for teeing that up. I swear David wasn't a plant at the end of this talk, but certainly holding space that, again, if the purpose of this data is to really reintegrate this new information about the excipient and how we may approach monthly LAI buprenorphine, right, in our clinical practice, always holding that loosely, that our population, not only with substance use disorders, but perinatal in general, has a history of, just because I can take care of this for you, like long-acting reversible contraceptives, for example, doesn't mean that that's the right fit for the patient, and that's the crux of patient-centered decision-making is really having those options available, and being able to have that support for a patient of what might work best for them. I turn this back over to you, Caitlin. I know we're at time, but I so appreciate everyone coming today, and welcome continued conversation about this, continued conversation about what direction things should be taking next. And again, I know there's some people on the call who I expect will have an upcoming, hopefully soon, journal club about other LAI buprenorphine formulations.
Yes, thank you so much, Mel. So thank you everyone for coming. I know we just kind of just got to the surface of the topic today, and so we still have a lot of. So please join us for our upcoming journal clubs. We'll make sure to make sure that we represent neonatal abstinence, neonatal opioid withdrawal, and more in upcoming conversations about buprenorphine, long-acting buprenorphine, and future journal clubs. To kind of get towards that, please save the date. Our next journal club is going to be Thursday, August 28th at 10 a.m. There'll be an invite going out soon, so we look forward to seeing everyone there. Thank you again for coming.
Thanks, y'all. Have a good day.